All right, hello everyone, and welcome to the second HFSA Cardio Town Hall focused on ATTR amyloidosis, titled Redefining Care and Expectations for Today's Patients, Early Diagnosis and Optimized Management. I'm Stephen Rodlin, Senior Medical Director at Alnylam Pharmaceuticals, and I'm once again just really excited to have the opportunity to open today's session. So first, I want to thank HFSA and today's expert faculty for their just continued leadership and collaboration. The previous inaugural session titled, What are the New Options? Lessons Learned from ACC was just a tremendous success. There was over 170 registrants, amazing engagement, and it really set the tone for thoughtful, in-depth discussions that this series was really designed to foster. So if you haven't seen it, I recommend going and watching it through the HFSA portal. So tonight's topic couldn't actually come at a more critical time. With earlier diagnosis becoming more achievable and treatment options expanding, the medical community just has a real opportunity to enhance optimized care delivery and patient outcomes. And that really includes meaningful patient-centered approaches that prioritize clear, accessible education, shared decision-making, and individualized goals for patients. And me personally and Alnylam, we're just really proud to support independent peer-to-peer education like this. So thanks for coming. Thanks for listening. I'm really thinking this is going to be a great discussion. So with that, I'll pass it over to our moderator for tonight, Dr. Michelle Kittleson.
Hello there. Thank you so much, Steve. We're so delighted to introduce the experts who will be telling us everything we need to know. I'm Michelle Kittleson, Professor of Medicine at Cedars-Sinai and Director of Education in Heart Failure and Transplantation at the Smith Heart Institute. Joining me is the amazing Dr. Sarah Cuddy, who's co-director of the Amyloidosis Program at Brigham and Women's Hospital and Assistant Professor at Harvard Medical School, as well as the awesome Dr. Spencer Carter, Assistant Professor in the section of Heart Failure and Transplant at the University of Utah and Cardiovascular Director of the Utah Amyloidosis Program. So let's dive in with an introduction. We're going to organize this into three sections where we talk about the three major challenges in the world of cardiac amyloidosis. I'm going to give a quick overview, and then we're going to punt it to our experts to squeeze them dry of all their knowledge. You can put questions in the chat that we will discuss as well. So, as you all know, cardiac amyloidosis is a condition where there's a protein the body produces naturally that, for reasons we do not understand, decides to infiltrate into the myocardium, resulting in a restrictive cardiomyopathy. The two most common forms of cardiac amyloidosis are caused by the immunoglobulin light chains, that's AL cardiomyopathy, which is a plasma cell dyscrasia along the spectrum from MGUS to multiple myeloma, as well as the transthyretin TTR protein, which in turn has one of two sources of variant or mutation in the gene ATTR-VCM or wild type ATTR wild type CM. In the olden days, we used to call that senile cardiac amyloidosis, but we do not anymore. That hurts people's feelings. So think about variant versus wild type, and remember that the protein just doesn't infiltrate the myocardium. It goes to other places as well, which can be clues. There can be neuropathy. There can be nephropathy unique to AL, gastrointestinal involvement, and musculoskeletal or orthopedic issues. So the first hurdle is to think of the diagnosis. If you don't think about it, you won't look for it. If you don't look for it, you won't find it. So what are the clinical clues? Remember that someone has heart failure with preserved ejection fraction. That is essentially a diagnosis of exclusion. So if your patient has dyspnea, edema, heart failure symptoms, and a preserved or mildly reduced ejection fraction, think about cardiac amyloidosis, especially if they have other findings, non-specific fatigue, other cardiac manifestations like AFib, AV block, pacemaker. Know that in case series of patients with aortic stenosis or thought to have HFpEF, about 15% have concomitant or underlying cardiac amyloidosis. Think about increased LV wall thickness and a QRS voltage that doesn't quite match. There can be neurological manifestations, a sensory neuropathy. There can be autonomic dysfunction, classically a patient with a little bit of hypertension, who you give a little bit of a vasodilating antihypertensive and they get profoundly orthostatic. That can be a clue for autonomic dysfunction. And think about those musculoskeletal manifestations, carpal tunnel, especially bilateral at an older age, spinal stenosis. These musculoskeletal manifestations often precede cardiac manifestations by 6 to 7 years. So that is a clue to the diagnosis. So with that foundation, I'm going to take it over to my two awesome experts. We'll start with Dr. Cuddy. Dr. Cuddy, can you tell me, what do you find are the most reliable clinical clues to heighten your suspicion for cardiac amyloidosis?
Yeah, it's kind of funny being asked this question because a lot of the time the patients come to me already diagnosed. So often the kind of classical line I'll see is older man over the age of 60, 65, LVH on his echo, and multiple orthopedic issues. Then I know this is going to be high yield. This will be highly likely. And I'm like, why didn't you think of amyloid sooner? Easy for me to say. When I'm in the echo lab, though, there's a number of times, anytime I see an increased wall thickness, especially the posterior wall, when I see it greater than 12 millimeters, in nearly every case, I think this is pathological. You know, the posterior wall, whatever about discrete upper septal thickening, but increased posterior wall, does their degree of hypertension really has it caused this LVH, especially if, like, let's say they've normal renal function, no proteinuria, something like that, that like you can't attribute it to hypertensive heart disease, then it's definitely worth like evaluating further, and especially in those older patients. So definitely when I'm in the echo lab, whenever there's increased wall thickness on the echo, and then either if there's diastolic abnormalities or looking at the indication, for example, a stroke and sinus rhythm and really thick heart. That was one diagnosis I made recently in the echo lab because I was like, this has to be amyloid.
Amazing. And that kind of clinical gestalt is so incredibly helpful. And just to point out what you so elegantly explained, LVH, left ventricular hypertrophy. Remember, it's not always muscle. Sometimes it's infiltration. So in your mind, think increased LV wall thickness. Do I really know what's causing it? I love that. And now for you, Dr. Carter. Now there are scores out there. There's the ATTR-CM score, 6 clinically accessible variables that can funnel into a probability of amyloidosis. Do you use these scores in clinical practice?
I think it's a really good point. And what Dr. Cuddy, mentioned is that the majority of patients coming to us in amyloidosis clinic have already been diagnosed. And so the scoring system is not as much for us for screening, but it's how do we do this on a system-wide level. So we've implemented a couple of scoring systems that we found to be effective, particularly in our TAVR program. So we personally use the RAISE score, very effective to kind of identify. And when you're in clinic, they are doing STS score and other kind of, cardiovascular risk, and so it kind of fits within their workflow. And so that's really where we're trying to integrate the scoring systems, is to high risk places, HFpEF clinic, TAVR clinic, spinal stenosis, to our orthopedic places, and really trying to get them to think of, hey, what's happening in this patient? Is there anything else that we need to think of? And I think both of your mention of LVH that has to be explained, really at the end of the day, our job is to explain things further. Every echo is a consult potentially, as far as what we're thinking about. And really, if you don't put it in the description on the echo, then the workup doesn't happen. So, one of the WashU papers that I really like is if you say, I am concerned for amyloidosis, the opportunity or the potential that it's going to be fully investigated is substantially higher than even if you say something like apical strain pattern, which you're insinuating think of amyloid, but if you don't say the word, then it's much less likely to actually be fully investigated. So I think from a scoring system standpoint, it's really those high risk areas and the people who could be thinking about it a little bit more, and it can help them integrate it into a workflow is really where we use it.
I think you both brought up such an important theme, which is that we can't exist within silos. We're always trying to take care of the whole patient. Why does this patient have dyspnea and edema? Why is the wall thickness high? Is there a unifying, satisfying explanation for why they also have carpal tunnel, spinal stenosis, neuropathy, family history? So we think like doctors no matter where we happen to be, clinic, echo lab, or somewhere in between. Now, that's the first hurdle. Think of the diagnosis, because it won't just pop up on normal testing. You have to think about it in order to order the right test. And that's the second hurdle. The 3 ±1 tests that you may require to come up with these 3 most common diagnoses. So you'll take these clinical clues you have from your history, your electrocardiogram, your echocardiogram, other imaging, and you will check a monoclonal protein screen. You will check the serum kappa lambda free light chains. You will check the serum urine IFE. If it is abnormal, you do not pass go, you do not collect 200. You remember that when it comes to cancer, tissue is the issue and you biopsy something. There are some subtleties to this algorithm. We all memorized in medical school, SPEP, UPEP, amyloidosis. Not so, not sensitive enough. Go for the IFE, immunofixation electrophoresis. And then biopsy, we all memorized in medical school, fat pad, amyloidosis. It lacks sensitivity. You may start with a fat pad because it is less invasive, but you cannot end with a fat pad. If the fat pad is negative, you must biopsy the organ involved, typically heart or kidney, to make sure you have excluded AL cardiac amyloidosis. Why is this so important? Well, if the monoclonal protein screen is negative, you and the patient can breathe a deep sigh of relief and then order some radionuclide scintigraphy, most commonly technetium pyrophosphate, though other technetium scans can be performed, to look for the presence of cardiac involvement. Now, here's the thing, though. This is amazing. This allows for non-invasive diagnosis of TTR cardiac amyloidosis, these amazing radionuclide scintigraphy scans. But 10 to 20% of patients with AL amyloid will have a false positive scan. So if you neglect to order the serum and urine tests to exclude a monoclonal protein and rely solely on an imaging test, you may miss a diagnosis of AL cardiac amyloidosis. Why is this important? What is the untreated survival of AL cardiac amyloidosis? It is less than a year. So don't kill your patient by depriving them of life-saving plasma cell-directed therapies. Make sure you've excluded AL cardiac amyloidosis by having a negative monoclonal protein screen when you are interpreting your technetium scan. And if it is positive, then you can do genetic testing, which will be useful for cascade screening of first-degree relatives. So that takes us through hurdle number 2. Now let's go to some more questions. Okay, tell me, Dr. Cuddy, are there nuances in the interpretation of the monoclonal light chains? I mean, what do you do if the kappa lambda free light chain ratio is abnormal, but the serum urine IFE, it doesn't show a monoclonal band? I mean, do you call your friendly hematologist? What comfort level should we have in interpreting these monoclonal protein screens?
Yeah, I think you really emphasized it so importantly that we do the whole screen. It's not just protein electrophoresis. It's not just the immune fixation, but it's also doing the serum-free light chains. Serum-free light chains, we've kappa and lambda, and either can be affected. It's not that it's always lambda, or it's not that it's always kappa. But they both are slightly different sizes and kind of cleaned out by the kidneys in different ways. So renal function can be one of the main kind of contributors to a mildly elevated kappa light chain. So in kind of updated algorithms, we see an adjustment to the kappa lambda ratio that can be acceptable based on EGFR. So I think, if you still feel that it's outside your comfort zone, you're definitely like well within your rights to reach out to your friendly hematologist. I know here where I work, we have an e-consult service, which I use, which is pretty handy just to say, hey, this was the kappa light chain, this was the this was the this, what should I do? Often for me, I'm pretty confident that I've excluded AL for some reason and it's maybe a high risk MGUS and I need their help on that because I see so much of it. But I think if you're not seeing a lot of it, really, it's great to have a hematologist on text that you can deal with. But more and more, I think we're trying to tell people, in an isolated elevated kappa scenario where it's just mildly elevated, renal function's abnormal, and you can adjust the kappa lambda ratio and it's still within what's right for that renal function, you can feel confident. I think any time that you detect a monoclonal protein, so if there's an M spike or the immune fixation shows the monoclonal protein, absolutely refer the patient to hematology and get their help with the workup.
Amazing. I think that's so important, meaning we empower people to start the workup because the diagnostic algorithm is not rocket science. But it's very important to also be empowered to ask for help when questions arise. So don't just feel you assume something's normal or maybe it's okay. You can call your consultants. We don't live in silos. We have a teamwork to get the right answers. And speaking of that, now, Dr. Carter, you will help us with this question. What are the important pitfalls that you encounter with the radionuclide scintigraphy performance and interpretation that clinicians should be aware of or should avoid?
Yeah, and maybe just to go back to the last question, just very briefly, the question is urgency as well. So we know with AL amyloidosis, time is a big issue. And so, where I did my training and our current philosophy is 7 days from a high risk, kappa lambda ratio or IFEs to biopsy and diagnosis. And so this is not something to wait, around months for, which is unfortunately something that we see at times with referrals in. From the PYP standpoint, it really, again, is the same. It's the quality of the testing. Is this being done at your center? Is this being done at an outside center? And how are you going to look at it? And so really, our philosophy is we look personally at every PYP or, whatever scintigraphy is being performed and make sure that we believe in the quality and really trust it before we start somebody on this expensive lifelong therapy and to get the right diagnosis. Obviously, there's a couple things that are absolutely key in addition to having the correct testing. Make sure we're doing cross-sectional imaging in addition to planar imaging. We're thinking, okay, what really are the potential downfalls or pitfalls? We review all initial testing with the hematologist every Wednesday. And so our program's approach to making sure we're not missing light chain amyloidosis, which can cause a positive PYP, one of the false positives, is to review all testing with the hematologist. And it's really helped us a lot. The second thing I mentioned, cross-sectional imaging, is blood pool. So we know that the agent is being put into the bloodstream, and if it's not performed at the correct time or a couple of patient factors, you might have a positive, quote unquote, test on planar imaging that's filling up the heart, but when you look at it, it's actually localizing to the blood pool or within the ventricular cavity as opposed to the myocardium. So really confirming that it's actually kind of within the myocardium is key for an appropriate diagnosis. From there, you also have to think of some of the more rare false positives. Some of those can be plaquenil toxicity is something that we think of, kind of in the very rare situation, or recent myocardial infarction. And then again, on the planar side of things, is there a broken rib on top of the heart? I think also importantly, when you're, looking at these, is the sensitivity of the testing. And so, the initial reports came out of 95, 100% sensitivity in addition to specificity. Unfortunately, we all know that that's really not the case. It's obviously a referral bias of people who are more advanced. And so thinking, hey, this doesn't make sense. This person has carpal tunnel, spinal stenosis, biceps tendon rupture. They have a quote unquote negative PYP, but is that where we actually stop our workup and stop our diagnosis? And so making sure, that we all recognize the relative lack of sensitivity in addition to, some of the potential false positives that we can see with the testing.
These are such important points because, again, we don't treat the test result, we treat the patient, and your pre-test probability guides your post-test probability. So if it's a slam dunk for amyloidosis, but you just aren't getting the answer you think you need to get from the imaging study, the scintigraphy, and the patient's just looking at you and it feels like it, then you're not wrong to biopsy something for further information as well. Like you said, it might be an early positive, it might be a rare form that has a negative on the bone scintigraphy, but you're never wrong to dig deeper if your pretest probability is still nudging you to say this is the right diagnosis. Now, before we dive into therapeutic options, I'd love to hear from both of you on your approach to the patient who has it's either a variant form, like let's say V142I identified through cascade screening, or let's say TTR amyloidosis identified on a carpal tunnels pathological specimen by a really smart hand surgeon. How do you approach cardiac screening in those scenarios? Dr. Cuddy, tell us your approach.
Yeah, so we did have a really smart hand surgeon and still do, who started a research protocol. So we screened 320 patients, sent off kind of very unrestricted, didn't limit it to older age or bilateral or other kind of orthopedic manifestations, just sent off the pathology. And we found 15% came back with some form of amyloid on their carpal tunnel. Now, some was even too scant for us to type, but the majority who we typed, it came out to be ATTR. So a lot of these patients, we found ATTR in their carpal tunnel. Initially, when we started seeing them, we were doing biomarkers, NT-proBNP, troponin, an echo, and also a PYP scan. But our yield from the PYP scan was so low that we said, hey, let's just take a step back here. Let's just use the echo, the NT-proBNP, and troponin. And if any of these are in any way abnormal, then we'll move on to the PYP scan. And that's the approach we've been doing. And we've bringing these patients back kind of between a year to 2 years. Now, this is very much clinical gestalt. If it's a 54-year-old woman, she had wild type TTR detected in her carpal tunnel, no other orthopedic manifestations. Echo looks completely normal. Like I said, tropes normal. I'll say definitely come back to see me 2 years. If it's an 80-year-old man with lumbar spinal stenosis, bilateral carpal tunnel, biceps tendon rupture, then I'll say you need to see me in a year because I think you're at a higher risk just from there's probably amyloid in all these areas. So I think we still have an awful lot to learn about the proper screening process, but this is just what we've done at our center.
I love that. Okay, Dr. Carter, do you want to battle Dr. Cuddy? Is she totally wrong? Tell us your approach.
Yeah, unfortunately, we all kind of fall in line. Maybe it's a good thing, maybe it's a bad thing. Who knows? We tend to, be a little bit earlier on the blood-based biomarker screening. So we screen the blood every 6 to 12 months, and then a little bit later on the PYP rescreening. So we'll rescreen at 3 to 5 years, again, depending on the clinical situation, how old somebody is, pre-test probability, et cetera. I think our current ongoing study, of ACT Early will really give us better insights and hopefully get us all on the same page as far as where we're going to go with this and will be, really helpful. So I think just really keeping that the antenna up as far as, is this patient getting worse? What's happening? Are there abnormal biomarkers? Is there anything else to think about? And then, I think novel imaging techniques that are coming down the pipeline with better sensitivity and specificity with the trellis and whatnot will be really, really helpful for this population. And hopefully in a couple of years' time, we'll be having a different conversation about our ability to catch these people and at what time. And then the question will be when to treat, as I think we'll get to in a minute here, but opens a whole nother can of worms.
Yes, and just for our audience, just in case you don't know what ACT Early is, you remember that this is an ongoing randomized trial of patients with the variant form without cardiac involvement who will receive acoramidis to see if there's a role in prevention. So stay tuned, very exciting. And now let's dive in. Okay, hurdle number 1 was think of the diagnosis. Hurdle number 2 was order the right tests, interpret them in the right way. Hurdle number 3 is pick a therapy. So if you think about therapeutic options for TTR cardiac amyloidosis, they follow a very pleasing pathophysiological progression. The problem is the TTR protein. You can stop making it with inhibition of synthesis through mRNA inhibitors. Liver transplantation, well, that is a bit extreme in the current era, thank you. And then we can move on to taking the TTR protein, which lives in a stable, happy tetramer form, and keeping it that way so it doesn't disassociate into these fibrils that deposit into tissue. So you've got silencers, stop the production. You've got stabilizers, keep it in its happy form. And then you have depleters that would suck the protein out of tissues not ready for prime time. So the therapeutic landscape currently includes FDA-approved guideline or evidence-based, I should say, FDA-approved, evidence-based stabilizers and silencers. And the cardinal trials you need to know about: the ATTR ACT trial, tafamidis; the ATTRibute-CM trial, acoramidis; the HELIOS-B trial, vutrisiran. All of these trials were randomized, placebo-controlled, and all showed benefit in the reduction of all-cause mortality and cardiovascular hospitalization, preservation of quality of life. What's really striking to also note about these trials is the point estimates of the event rates. And what you notice is as you get into successively more current eras, the point estimates for the event rates get successively better even in the placebo group. So good job, everybody. What does this mean? We're diagnosing earlier. We're treating heart failure better. Because these therapies, it's very important to counsel patients, do not reverse disease. They're not meant to make you feel better. They should slow or halt the process of feeling worse. And clearly we're getting better. So what we can say with these therapies is they all work, but there are no head-to-head trials to say what works better than something else. So with that, let's dive then into the final portion, which will be the discussion about therapeutic options. Okay, Dr. Cuddy, how do you approach this conversation regarding our embarrassment of riches with now 3 disease-modifying therapies for ATTR-CM?
I know, I've had to ask for longer appointments. It used to be pretty easy. You would one appoint a drug and you said, this is what we've got. And now it's a much longer appointment with every patient because established patients are coming back saying, hey, I saw an advert on TV or I read something in the New York Times. Um, and then the new patients, it's really getting a lot of discussion. I actually love giving patients resources. There's an abundance out there. My personal fave is the Amyloidosis Resource Consortium booklets, which kind of go through the disease, the diagnostic pathway. So we're able to talk through that at the first appointment, and then the therapies. So I can kind of circle which is an injection, which is in a tablet, the frequency of the doses, because little things like this can have an impact on the person making the decision. You know, they might say, yeah, I think I'd like the idea of an injection once every 3 months, or I think I like tablets, I'm going to take a tablet. So it's very much per patient that I have this diagnosis. And kind of like you say, I have to tell them, look, we can't say that we've put 3 people on the drug and who did better out of those 3 on the 3 separate therapies. We just don't have that data. So really, I reassure the patients that we know all these therapies are effective and have been shown to help keep people alive longer and keep people out of hospital longer. So really, it's a very individualized kind of approach that I have with each patient when starting this conversation.
Which is in fact very reassuring because it means AI will not replace us. There's so much nuance here. Dr. Carter, do you have any other different approach when you're having this conversation about the therapeutic landscape?
And I think it's just so different with every patient. One patient that I saw, came in and had the ARC last webinar, printed off all the slides and was telling me, about trials and such. And obviously, it's a very, very different conversation than you're having than someone who's the first time they've heard of amyloidosis. So I think really trying to structure the conversation to where someone comes, where they're coming from, really is important as we have those discussions. And really, it is that discussion between patient and provider to come up with the right option. But I think a lot of it too that we've mentioned, vaguely is where people are. So we take care of people from a very broad 8-state region, and somebody who's in the middle of nowhere, Montana, doesn't have an infusion center, within 200 miles. It's a pretty obvious choice that, the vutrisiran is unfortunately not a good option for them, just given their constraints. And so really taking the patient's life and are they able to take medicine? Are they able to take a twice-a-day medicine, et cetera, into the conversation, in addition to the scientific things where we might have some preference depending on some of the comorbidities and such. The specific reasons why we might be more or less interested in one versus the other, I think is a second conversation, which I think we can probably start now. And so the first is, is this a wild type patient or is this a hereditary patient? And I think maybe there's a little bit of nuance there as far as what might be beneficial or not. And do they have polyneuropathy or not? And so patients that we in particular are very focused on putting on silencer treatment are those who are hereditary or variant patients who have a polyneuropathy in addition to a cardiomyopathy. We think there's pretty clear evidence that that's very beneficial. Outside of that, it starts to get a little bit shakier as far as benefits, but that's really kind of, I think, solid ground that we've coalesced upon. Our program, we have multiple providers seeing people. We've come up with 4 or 5 kind of general ideas about what's happening and what we want to do. So if we say, hey, this patient is getting worse, their troponin's getting worse, they're getting admitted to the hospital, their NT-pro is going up, let's think about switching therapies, meaning switching drug classes if they're on single therapy. And who knows if this is effective or not, but at least from thinking outside of amyloidosis and things we do for other patients in different disease states makes sense. So that's kind of a group that we're focused on as far as potentially switching lines of therapy and is helpful. Maybe I'll stop there, and I'm sure Dr. Cuddy has some thoughts about others, who you might think go one way or the other. I'm always interested to hear.
Yeah, I think it's very interesting bringing up this kind of concept of switch. Because sometimes as the physician, you have to have the kind of tough conversations with the patients. So when we have to look at the populations recruited into these studies. And yeah, we see, as you mentioned, Michelle, these really great increase in like the point estimates, their survival in these patients. But that's a lot because the Helios B study did not include patients with NYHA class 3 or NAC stage 3 disease. So NAC stage 3 being an NT-proBNP greater than 3,000 and EGFR less than 45. The average diuretic dose was around 40 to maybe 80 of furosemide. So when I'm seeing my patient who's on 100 of torsemide BID with PRN metallazone doses, maybe more than once a week, with clear NAC stage 3 disease, NYHA3 symptoms. I think talking about switching therapy there, unfortunately, is maybe giving false hope. So definitely with those patients, I kind of have to have a challenging conversation to discuss goals of care and things like that. But I think, Spencer, I totally agree with you. Maybe the earlier patients, now that we're seeing all these amazing sub-studies come out of acoramidis study, ATTRibute, and the Helios-B study of vutrisiran, we're getting all these better ways to monitor disease progression and maybe pick up earlier when our patients are progressing. And I think the next several years will generate really cool data on switching, but we don't have the data there. I think a lot of us are kind of taking your approach and kind of a very much clinical gestalt. One other reason for me to pick one therapy over the other is ongoing clinical trials. So I'm always trying to get patients into trials, and there is ongoing CRISPR study to again knock down the protein production at the level of the liver. And there's more silencer studies in the pipeline. So if the patients can be in a stabilizer as part of standard of care and enrolled in that study, that will also push me maybe to put them on a stabilizer baseline.
This was extraordinary. I have learned so much. So I think we can say we have 3 therapies that work. We can't necessarily say which one is better than the other, though there's clearly evidence and FDA approval if you have the variant form with neuropathy for vutrisiran. And otherwise, there's little data to support switching for progression, though all of this boils down to shared decision-making. So to summarize, we know patients are appropriate for disease-modifying therapy if they've confirmed ATTR-CM, class 1 to 3 symptoms. As Dr. Cuddy said, if you're class 3 with NAC stage 3, you were excluded from Helios-B, but otherwise class 3 were allowed. And those with milder symptoms, since this doesn't reverse disease but slows or halts progression, derive greater benefit. When it comes to heart failure therapies, we know that diuretics are a necessary evil. We know that MRAs and SGLT2 inhibitors may assist in relief of congestion. And don't forget to anticoagulate for AFib, regardless of CHA2-VASc. We talked about vutrisiran for the cardiomyopathy and polyneuropathy, and dealer's choice when you're coming to the patient who has wild type or variant without polyneuropathy. Go by patient preference, access, and that essential discussion, the physician-patient relationship. Well, thanks so much. There you have it. I'm Michelle Kittleson. It was a delight to moderate this session. And don't forget our upcoming programs. There's 2 more cardio town halls in amyloidosis, one of assessment of the progression of disease, real-world optimization, and evolving guidelines, advances in standard of care. Thanks so much for being here.